Thank you for joining us for conversations and updates in gastric and GE junction cancer, practice-changing expert insights to improve outcomes. This activity is titled Practice-Changing Updates in the First-Line Treatment of Gastric GE junction cancer. And during this segment, we will be discussing systemic treatment of advanced gastric GE junction cancer HER2 negative. I am Manish Shah, Chief of the Solid Tumor Oncology Service here at Weill Cornell and Professor of Gastrointestinal Oncology. I am joined by my colleagues, Drs. Yelena Janjigian and Dr. Samuel Klempner. And so today we'll be talking about the role of biomarkers in the first-line setting, and we'll update some of the recent studies that have shown, in practice-changing results. So by way of biomarkers, I think I just wanted to start off by saying that the role of biomarkers in upper GI cancers is still relatively new. Although, since the 1990s, we've been doing HER2 in breast cancer. Really, HER2 became an important aspect about a decade ago with the TOGA study, which demonstrated that for HER2 positive gastric cancer, the addition of trastuzumab to chemotherapy was much better than chemotherapy alone. And since then, we've had a lot of progress. The biomarkers, there are many biomarkers that are now used in gastric cancer. I might begin by, sort of talking to the experts here. So, Dr. Klempner, what biomarkers do you routinely get in the first-line setting for someone with metastatic gastric cancer?
Yeah, I think you hit the point, which is just need to get biomarkers for absolutely everybody. The standard is mismatch repair deficiency and HER2. We do get PD-L1 for everyone, and we do the CPS score across histologies still, although I'm sure we could debate about what's the best assay and scoring system. At our institution, we additionally do panel-based sequencing for everybody. Admittedly, it may not inform the first-line management, but because of the availability of clinical trials and interest in exploring potential other targets, which I'm sure will come up, we do that for everybody. So MSI or MMR status, HER2, and PD-L1 for all new diagnoses.
And how about you, Dr. Janjigian?
Yeah, it really depends on tissue availability, but most of our patients come in with ample tissue or get a baseline endoscopy done, and reflexively we test first for IHC on MMR, and then in addition to that, as Sam mentioned, NGS is subsequently done for TMB and other co-occurring alterations. And it really informs also the germline analysis, sporadic germline alterations in BRCA, even Lynch, CDH1, CHEK2 alterations and so forth may have impact on patients' risk and their families. And so germline analysis in gastric is really important. And then it gives you a roadmap of what to look for if you're interested in liquid biopsy and ctDNA monitoring, because for example, for HER2 and MSI tumors, that's helpful. PD-L1 should be done on all patients. You may not choose to use it to restrict, but you really should know the information. And we also do HER2, obviously, and EBV in all cases.
Yeah, so I think you mentioned something that's important. You said reflexive testing, and I think for our audience, so what that really means is that as soon as a diagnosis comes in, the pathologist knows to get a certain battery of tests, and I think that can be very helpful because as was said, I think these are all important studies to sort of help guide our treatment. So what we do is HER2 immunohistochemistry, mismatch repair immunohistochemistry, and PD-L1. So that's all immunohistochemistry. And if there's tissue available, we also do next generation sequencing. But I understand that may not be available for everybody. And then from a tissue agnostic standpoint, with next generation sequencing, you can get TMB, which may be another kind of indicator for immunotherapy if you're not using it, depending on the PD-L1 status. So I think we're all in agreement with regard to the importance of the biomarkers, and I should say that we also do it reflexively. These are just things that are done based on our discussion with pathology. So let's dive into some of the data that helps us inform how we use this information. So I mentioned earlier at the beginning the TOGA trial, which really established trastuzumab as a standard of care for HER2-positive gastric cancer. And there'll be another session on HER2-positive disease specifically. But let's talk about PD-L1 testing. So I think we all recommended doing it. That's really, based on this landmark study that Dr. Janjigian ran, the Checkmate 649 study. Maybe Dr. Janjigian will take advantage of your insights, and if you could just summarize that study briefly.
Yeah, sure. So as you mentioned, in first-line HER2-negative space, we had relative dry spell on biomarker-directed studies, VEGF inhibition with multiple attempts. EGFR, MET has been negative. So Checkmate 649 came on the heels of Keynote 62, where also first-line immune checkpoint blockade was assessed and unfortunately did not meet its pre-specified cutoffs of benefit. The difference between Checkmate 649 and other studies in that space was that this was a large global study that included esophagus adenocarcinoma together with GE junction and gastric cancer patients, which we know biologically from the TCGA and other efforts. Those are, they are much more similar in terms of biomarker and drivers, aneuploidy and chromosomal instability than, let's say, squamous cell cancers. And Checkmate 649 was a large study. It was over 2,000 patients were treated. The primary endpoint was in PD-L1 CPS 5 or greater for addition of nivolumab to chemotherapy that you and I like to use in the clinic as backbone, which is FOLFOX, as opposed to high-dose cisplatin or other, platinum options. And ultimately, it was a positive study in all comers, intent to treat population, while the benefit for PD-L1 CPS 5 patients, which was the primary endpoint, was the most robust. And then the curve separated early on, although the hazard ratio in all comers and the median survival was also improved. For the first time in a long time, we were able to cross the 1-year median OS for HER2-negative disease, right? Because we've done okay with the TOGA, but not for HER2-negative. So it was definitely a practice-changing study. There was a lot of discussion among experts in Europe and even folks in the United States. Should we have CPS as the as a gateway as to which patients you're going to treat? Many regulatory authorities worldwide, including the United States, Japan, and others, decided to leave that decision with the clinicians and approve the use of nivolumab irrespective of PD-L1 status. And then each of us have our own sort of decision points as to how we decide who to treat or not to treat with nivolumab in first-line setting in terms of, efficacy benefit risk ratio.
Terrific. Thanks so much. I'll maybe talk about 590, and then Dr. Klempner, maybe you could talk about attraction 4. So in terms of Keynote 590, this was another study, a first-line study of chemotherapy with or without pembrolizumab. Dr. Janjigian highlights some important differences between Keynote 62, which was a gastric study, and Checkmate 649, which was a gastroesophageal study. But so Keynote 590 was a large study, about 700 patients in esophageal carcinoma, both adeno and squamous cell cancer. And similarly, it was, the addition of pembrolizumab was active in all comers, but it was probably driven primarily by squamous cell cancer and the CPS of 10 or higher. With regard to adenocarcinoma CPS 10 or higher, at least for the first time, we saw that in esophageal cancer, there was a hint of activity. The hazard ratio was similar to the overall hazard ratio. So based on Keynote 590, pembrolizumab is approved in the first-line setting for CPS 10 or higher for all comers. And then Dr. Klempner, do you want to briefly talk about attraction 4?
Yeah, I think, one thing to keep in mind that's always very humbling and sobering is that even in our positive trials, the median overall survival improvement in absolute terms is like 2 to 3 months in these ITT populations. And it's something that, highlights we still need a lot of work to do. Attraction 4 is an Asian gastric cancer trial primarily, essentially asking the question about the addition of nivolumab to CAPOX or SOX, which are common backbones in Asia. This was, for overall survival, was a negative trial. For PFS, it was positive, but I think there's a few things in the patient population worth noting. There's a lot of diffuse type patients in this trial, which tend not to derive as much benefit. PD-L1 was not a criteria, but it was captured by TPS score. And so TPS positive and negative, and there's a large number of TPS negative patients in this trial.
80% or more were negative.
Yeah, it's like most people. And then there's, almost half the patients had peritoneal disease, which is another poor prognostic feature and an area where perhaps IO may actually not provide as much benefit. So it directionally is consistent with the idea of, biomarker expression may select people who have benefit, but it was a negative study for survival.
Yeah. So with gastric and GE junction cancer, I think, and also for esophageal cancer, I think that there's agreement on the panel that the higher your CPS score, the more likely you are to derive benefit for adding a checkpoint blocker to chemotherapy in the first-line setting. And I think, as Dr. Janjigian said, we kind of each have our own thresholds for where to use it. Although in the U.S., just to reiterate, nivolumab is approved in the first-line setting for all comers, independent of CPS status. And maybe I'll go around the panel just to see sort of what your practice is. So for me, my practice is that I really do limit its use for CPS 5 or higher. I think that the data for less than 5 for this large study is the benefit is not as much as for 5 or higher. And Dr. Klempner, how about you?
Yeah, I think we're pretty similar. I was kind of impressed with this recent meta-analysis in JAMA Onc, sort of asking similar question, pulling all this data. And we want to make sure that our team has reviewed it because there's obviously some testing variability. We like to have a contemporaneous biopsy. We really do try to give the patient the best chance of getting into that 5 or higher group. But in general, for the majority of patients, our institutional practice has been for CPS 5 or higher to add.
How about you, Dr. Janjigian?
It really depends on the quality of the test, and as you probably know, that for CPS 1 to 4, the concordance rate between different pathologists, because combined positivity score involves number of cells that need to be counted in the sample overall, and then looking at the positive cells both in the tumor and the stroma, there's a lot of variability. So the answer is always to try to put those patients on a clinical trial, and we have first-line studies for the HER2 for the PD-L1 intermediate or low patients. But if I have to be really completely honest with you, outside of a trial in a patient who's fit and is willing, and we do discuss the pros and cons, I feel uncomfortable with holding immune checkpoint blockade in first-line setting. And the reason why is because in most of the phase 3 studies, ORIENT 16, ESCORT studies, and CheckMate 649, the rate of CPS 5 or greater should be 60% of the patients. And that's because it's a controlled setting with very good tumor content and pathology centrally reviewed. In even our practice and practices, when I go give talks, grand rounds, and so forth, people are reporting CPS 5 or greater positivity of 25%. I can tell you with clear contest, CheckMate 649 was not an enriched population. So that means we're underdiagnosing, or pathology, tumor content issues are a factor. Maybe use of different antibodies, because CLIA-approved antibodies, once it's CLIA-approved, there's 5 different antibodies that can be used. With that, I just don't feel comfortable telling someone that they're PD-L1 negative, unless, again, as Sam mentioned, our pathologists reviewed it here and clearly feel comfortable.
That's very fair. So you mentioned the other Orient studies. So the Orient 1 and Orient 15 were both squamous cell cancer studies, and they're I just want to highlight the other PD-1 inhibitors in squamous cell cancer. So the Orient 15 was sintilimab, which is a PD-1 inhibitor. It was a study performed in China in squamous cell cancer in the first-line setting, and there was an improvement in survival in esophageal cancer with the addition of the sintilimab. And then the ESCORT-1 study was another PD-1 inhibitor called camrelizumab, and that also showed improvement in survival. There is activity of checkpoint inhibition in the first-line setting, and certainly, I think we all agree that the higher your CPS, the more the benefit is. And I think with these options, we have an opportunity to be able to individualize our care and give the best care we can to all of our patients. So thank you again for joining us for this segment on systemic treatment of advanced gastric GE junction HER2 negative cancer. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, or ACPE credit, access supplemental slides and other topics, segment, and case scenarios. Thank you.